All right, everyone. Good evening once again. My name is Erasmus Okello, and you are welcome to today's episode of the Statewide Anesthesia and Critical Care Seminars. We are covering pulmonary physiology, pulmonary disease in critical care. This is brought to you by the two associations, the Association of Anesthesiologists of Uganda and Intensive Care Society of Uganda. We are available on the multiple channels shown on your screen, and you can always click on those and get more information about these two associations and the activities, as well as more information about this seminar that we have. This episode 5, we have had 4 episodes, all of which are uploaded to our YouTube channel, and you can always visit the channel and review the information there. In today's session, we will be continuing with our goal of trying to raise your awareness of the power you have to intervene and save lives and tool you better to save people who come in with probably the commonest symptom that brings people to hospital. Apart from failure to get an erection, failure to breathe is one of those reasons as to why people rush to hospital. The other, of course, is bleeding, all of which can happen in the setting of respiratory failure and lung disease. And so you are in the right place. Previously, in the last session, that's last week, on Friday, we were focusing on pulmonary hemorrhage, and we had quite a big cast taking care of the topic. We had a clinical case presented by Dr. Vanessa, followed by pathophysiological approach to diagnosis and eventually massive approach to care of a patient with massive pulmonary hemorrhage presented by Dr. Batha and Dr. Lillian, respectively. The session was concluded by Dr. Tomanya, who took us through quite a fine talk on lung isolation and one lung ventilation, something that's quite a lifesaver in critically ill who have massive unilateral bleeding. The session was chaired by Dr. Lamek, who's an intensivist and an anesthesiologist working with Uganda Heart Institute, NHL, as well as Makerere University. Our recordings, as mentioned earlier, can be found in this channel. Just click on that link and you can always access the videos. During that session, we agreed that pulmonary hemorrhage is a cardiorespiratory emergency that requires a multidisciplinary approach, which is quite time sensitive. And in that case, you want to be able to notch a diagnosis quickly, especially in determining whether this is a localized unilateral disease or it is bilateral, and whether the condition is acute or acute and chronic, and what etiologies might be playing a role. And then in terms of the interventions, you definitely want to make sure you get an early control of that airway in terms of intubation and isolate the bad lung quickly so that you don't have swell the good lung, which is going to be your friend. And usually, depending on how much bleeding is happening, you may also have to activate your massive transfusion protocol and care for the rest of the physiological derangements that follow when a patient bleeds into their lung. For example, there may be an acute loading of the right ventricle with right ventricular failure that could lead to death. So you may need to handle that bit as well. When you are playing with the PEEP, in these patients, remember you're dealing with one lung predominantly, and so you want to be careful with your PEEP. But there's a possibility when you have isolated lung nicely to actually ventilate the two lungs in separation. Other consultations might involve consulting surgery for what is good for the patient, as well as intervention radiology, where possible for them to embolize the affected part. Some patients, unfortunately, are extremely too sick and you can't do much about them. So you may have to consider palliation when you realize that your intervention may not lead the patient to a favorable outcome, and the patient may not necessarily survive the particular event. So today we move on to restriction in breathing. This is probably something that we've all suffered from at some point. I mean, to a lesser degree, of course, you never ended up in ICU, or some of us may have, unfortunately. It's a multi-etiologic condition, but specifically, we're going to talk about the kind of physiology where the patient is trying to breathe in, but there's inadequate room to take in air, and so they are quite sick. And in this session, we're going to be mentored by Dr. Preach Kavata, who is an internist and intensivist currently residing in Cambridge. He is back home in Cambridge and is coming to share knowledge with us, having mentored a team that will be presenting today. Myself, Erasmus Okello, and Dr. Cornelius will be the moderators of this session. And as I mentioned, it's a big cast. Dr. Daphne Tukwase will be taking us through the case of the day. Then Jonathan Mugenyi will go through the pathophysiology of these diseases, followed by Dr. Caesar, who will take us through an approach to therapeutics, including how to ventilate these patients. Dr. Joyce Kalunji will put in an expert touch on how any additional interventions that may be called on to in such patients who may not be able to do well with just conventional therapies. So as usual, kindly mute on joining. Share your questions on the chat whenever the call is made, and occasionally we'll allow you to raise your hand and ask the speakers directly at the end of the talk. When time allows us, we shall also run some calls that will spice up the talk. So without any further ado, I would like to retire my slides and invite the first speaker. Dr. Daphne Atkwase is a resident in Anesthesia and Critical Care Department of Macquarie University, and she will be presenting the clinical case for today. So Dr. Atkwase, kindly share your slides. The floor is yours. You've got 20 minutes for the talk so that we can save time for the conversation. Kindly share your questions on the chat. Then we shall tackle them at the end. Thank you. Dr. Daphne, in case you are speaking, you're on mute.
Am I now audible?
Yes, we can hear you.
All right, so the objectives for this session are going to be getting the patient's history, the initial assessment and interventions given to this patient, the lab and imaging and their results, a summary of events for when the patient was admitted, the discharge plan for this patient, and probably at the end, we'll be able to discuss what we probably learned from the case or how better the case would have been managed. Yeah. So we had TS, a 28-year-old male who had been treated for PTB last year, and he had presented with a productive cough for a month, chest pain, and difficulty in breathing all for a month. So he was transferring from another facility with history of PTB treatment last year, which had resolved, but over the past few months had been having a recurrence of respiratory symptoms and getting frequent admissions. And for most of these, he was actually managed as a pneumonia patient. He improved and would get discharged, and then a few weeks later, get the same symptoms, admitted, and then discharged. So currently for this episode, he has been sick for a month. And for the first 2 weeks, he was admitted in a different facility and still being managed for severe bronchopneumonia before he was transferred out due to absence of a bed in HDU or ICU. However, no hemoptysis, and all his symptoms were progressively worsening. In the review of other systems in the CNS, we get episodes of confusion every time the difficulty in breathing starts. The GIT and CVS were really unremarkable. In our past medical history, he He had multiple admissions, like we have already seen, with respiratory symptoms, and also had a history of PTB treatment, which he completed for 6 months. We've already seen that he was a transfer in. We're not able to get history about his childhood illnesses and admissions. Notably, he was HIV seronegative after multiple determined tests being run. He was not diabetic or hypertensive, and he did not have sickle cell disease. He worked in the UAE, but was deported due to an illness which was still undefined. No history of heavy alcohol intake or smoking. In our examination findings, at the initial encounter with the patient, he was sick looking, cachectic, febrile, was pale, he had generalized lymphadenopathy and was dehydrated. Our vital signs at the time, the BP was 9254, pulse 136, SpO2 was 75 on room air, respiratory rate 34, and a temperature of 36.2. In the respiratory system, he was in obvious distress. He had reduced breath sounds over the left upper zone. He had diffuse bronchi over the entire chest. And with that SpO2, of course, an intervention was immediately done, which was an rebreather. And on putting him at 8 liters, he went up to 98%. NCNS was disoriented in person and time, but he was okay in terms of place. He had a GCS of 13, the pupils were equal and reactive. All his limbs were moving nicely and normally, so no focal deficits. In our cardiovascular, he was warm. Our cup refill was less than 3 seconds. No more heart sounds, no murmurs. The ENT, he only had an erythematous oropharynx. The abdominal findings were all normal. So basing on that, well, this goes to you, the audience. What would you think was the patient's issues at hand? You can just type in the chat, really. Yeah, so basing on that history and our initial examination, our number one diagnosis was recurrent PTB, probably with progression to ARDS. We're also suspecting he could be having COVID, pleurisy of TB, post-TB lung disease. Other differentials are idiopathic pulmonary fibrosis, non-specific interstitial pneumonia, pulmonary vasculitis, immune deficiency syndrome that we were not able to ascertain, but we queried Mendelian susceptibility to mycobacterium disease. Again, if you have any other differentials that you think, based on the patient's history, he could have had, please type them in the chat. And also for us to think about what would be your next steps in the management of this patient. So basing on where we were, our next step was to order some investigations. Of course, after stabilizing him with some oxygen, and the investigations were CBC, malaria test, CRP, procalcitonin, blood cultures, arterial blood gas, COVID-19 test, and a high-resolution CT scan. And our initial treatment was oxygen, IV paracetamol to help with the pain, and IV hydrocortisone. So our initial CBC looked like that. With that neutrophil count, total white cell count of 3.6, neutrophil percentage of 74.3, but an absolute neutrophil count of 2.74. The lymphocyte percentage, 21.3. I guess we can now peruse through. Our HB was 8.2 at that time. And then our platelets at the time were 283. RFTs and electrolytes, that's our creatinine, which is slightly below the normal range. Rare was normal, sodium, potassium, chloride were all normal. So in other results, this may not have been instant, but yes, the sputum analysis was unremarkable. The gene expert was positive. The lymph node biopsy was positive for acid-fast bacilli. This was the first biopsy done. Then the CRP was 30. The reference range for that particular lab was up to 1. The procalcitonin was 12 nanograms per mil, and normally you expect it to be less than 0.05. Yeah, so a few hours later, after getting the results, patient was still reviewed and he was unwell, cachexic, and now he had a fever. He was in extreme distress and he was anxious. And at this point, our BP was 85/54. The pulse was 128. The respiratory rate was between 35 to 52. And the SpO2 had now dropped from the initial 98 on NRM and now was at 91 to 94. Our SpO2 was 41 on room air, 91% as we have seen, and yet diffuse crackles. In the CVS, he was cold. The pulse was thin and thready. He had a normal JVP and had sounds. CNS was fully conscious, but anxious, and was able to move all the limbs. In the abdomen, we really only had an enlarged liver of 4 centimeters below the subcostal margin. The skin exam was really normal. So at this point, the diagnosis was sepsis with septic shock, probably due to disseminated TB, vis-a-vis superimposed bacterial or fungal or viral infection. We also thought he was in respiratory failure. He was cachexic and queried pulmonary hypertension. So our plan at that time was changed to CPAP by NIV, reinstitute anti-TB treatment, start on meropenem, vasopressin, Dexa, bosentan for the pulmonary hypertension, IV fluids, as we said initially, he was dehydrated, VTE prophylaxis, rabeprazole, and then chest physio, encourage oral feeding, and then do ECG and echo. So this is a screenshot of our high resolution chest CT scan. And the findings were bilateral multifocal, multilobular, patchy coalescing, predominantly ground glass opacities, with superimposed multifocal, densely consolidated regions, demonstrating air bronchogram and a halo sign in some regions, and tendency to white lung pattern. The opacities were exhibiting intrinsic enlarged vascular sign. The bilateral interlobar fissural sites were prominent. There's left hemithoracic opacity demonstrating a meniscus sign, which was suggestive of pleural effusion. Yes, CT involvement score, we had approximately 80% of lung parenchymal tissue being involved. And we had a severity score of 24 out of 25. So we can see how bad that was. I guess the radiologist will be able to elaborate on that part. Yeah, that's it for those lungs, right and left. The mediastinal window, left hemithoracic fluid collection, multiple abnormal lymph nodes in the mediastinum. Yeah, and that was the conclusion. And these are the images from the chest CT scan. Yeah, we can see the extensive fibrosis with very little to no lung tissue on the left side. Yeah. I guess still on these, the radiologist will be able to give us his view. So as we are going to see later on in the management while on ward, certain other investigations were requested. So we're just going to display all of them in a row, and then we'll talk about the progress notes. Yeah. So later on, we had the brain CT requested, and we can see the extensive brain atrophy. And this is a 28-year-old male, but he has a brain of a 75-year-old. In our abdominal ultrasound, the biggest, I should say, finding there was diffusely thickened walls in the colon with thickened subadjacent mesentery noted. We had multiple enlarged abdominal lymph nodes, and then we had ascites. And then the liver also had masses in there, and it was also enlarged. Like we said, later on, we kept on requesting certain things. So our tracheoaspirate cultured Klebsiella that was sensitive to those drugs and resistant to the ones we are seeing. So in summary of this patient, so after the initial review, reviewing them the day after, he had developed seizures. He had high-grade fevers with temperatures going up to 40 degrees. Of course, he still had cough, chest pain, and difficulty in breathing as expected. And he was still hypotensive even on the vasopressin, excuse me. So the management for that, of course, anticonvulsants were instituted, antipyretics and analgesics. Antibiotics, Dr. Erasmus asked us why vasopressin was chosen, yeah? Maybe you're also going to tell us why linezolid and amikacin and meropenem were chosen. Remember, this is someone who is on anti-TBs, yeah? Yeah, so IV fluids, mucolytic and expectorant, and then on top of the vasopressin, noradrenaline was added, then fentanyl infusion for the pain, and then we maintained the NIVC PAP. And at that time, the brain CT was requested. Those results we have seen earlier. On day 2, significantly, we had those deranged electrolytes. And of course, we still had the fevers and the cough and the chest pain. All through week 1 to week 2, we still had fevers and we still needed vasopressors, yeah? So on day 3, our oxygen demand was really increasing and we started desaturating even on the non-rebreather. At 15 liters, the maximum we could go was 88. Yeah. An EBG at this point was requested, which showed hypokalemic, hyponatremic respiratory alkalosis with very minimal metabolic compensation. And at that time, a decision to intubate the patient was made. And after intubation, he was placed on PC, SIMV. I guess when Owori is discussing, he'll let us know if this was the best mode for us to ventilate our patient on. Yeah, patient was then sedated with fent, ketamine, midas. And on top of the NORAD and vasopressin, we added adrenaline. And then we had to now continue with our electrolyte replacement. By the end of the first week in ICU, we had reduced vasopressor requirements. We were anemic and we still had fevers. So we started tapering the vasopressors. We transfused, continued, of course, the antibiotics, analgesia, sedation, and all the rest. And then our blood culture was ordered. So in week 2, again, after trying to taper the vasopressors, BP still went further down. So now we still had to increase the vasopressor. And then, of course, we still had fevers. And now our sputum became purulent. And we still had on and off seizures. So that is when we decided to take the tracheoaspirate and then increase the dose of anticonvulsants, and then also transition the patient to a tracheostomy tube from the ETT, because this is week 2. Then in week 3, the patient had started showing some signs of improvement. The fevers were starting to go down, much as we still had intermittent fevers. The patients were still there, and now the pleural effusion had actually increased. Yeah, we had there was a POCUS done, a chest ultrasound. Yeah, and at this point, we decided to put a chest tube, and then of course, regular suctioning of the patient. This is the point when the Klebsiella results from the culture came in. And since they were responsive to ceftazidime, we added ceftazidime on the regimen that we had. In week 4, patient kept on improving, but developed agitation delirium. And at this time, our electrolytes were normal. So we stopped electrolyte correction, weaned the patient off the vent, weaned off the steroids. We started him on fluoxetine for the agitation delirium and depressive episodes. And of course, meanwhile, all through this time, we're actually doing chest physiotherapy. That has been happening from the time the patient was admitted. Then in week 5, nothing new, nothing much going on. So our main aim was to wean the patient off the vent, which was done. And by this time, the patient was on Swedish nose. And by the end of week 5, patient was really in HDU on PRN suctioning and nebulization with hypertonic saline. And of course, nutrition replacement. In week 6, after all this improvement happening, patient started having abdominal pain and vomiting. And then he was anemic. And obviously, we still had reduced breath sounds. And we planned to discharge him after the vomiting and abdominal pain had been worked upon. For his anemia, he was transfused, and a post-transfusion CBC was requested. At that time, the HB was 9.6 post-transfusion. An abdominal ultrasound scan was requested as well due to the abdominal pain, and we have seen the results up there showing you abdominal and colon involvement of the TB, what we think is TB. Yeah, so after week 6, in week 7, midweek 7, the patient was planned for discharge, and this was his discharge plan. He was going to be on home care with a trained critical care nurse, and he would have an anesthesiologist review daily, and then PRN, like when called in, yeah? And then our discharge diagnosis was resolving respiratory failure, secondary to multi-drug resistant disseminated TB, resolving septic shock, yeah? He was discharged on metro, rabeprazole, rivaroxaban, bosentan, pred, fludrocortisone, potassium chloride, vitamin D, an adrenaline infusion, which of course the nurse was to take care of, NGT feeds, and he was to continue with his anti-TB medication. I think this brings me to the end of that presentation. Thank you so much for listening. And I think at this point, we can have the questions, supplements, concerns, clarifications. Yes, depending on what Dr. Erasmus is.
Excellent, Daphne. Thank you so much. This was a lovely presentation and quite thorough. Yeah, so there've been quite a bit of a discussion on the chat. And yes. I see the mentor of the day, Dr. Preach, has been responding to some of the questions on the chat. Could we have those who wish to ask could raise their hands? In the meantime, Dr. Preach, could you just give some sort of a closing remark on the presentation and what your thoughts might have been for this particular patient and the choices of treatment? Yeah, over to you, Doctor.
Thank you very much. And thank you very much, the presenter, for such a beautiful presentation. As you have seen, this gentleman was 28 with significant TB and a lot of things were not making sense. If you noticed in the presentation, he had generalized lymphadenopathy. And the first time I saw this, my first question is, what was the HIV test? And as you have heard, the HIV test was done multiple times. Now, had the HIV test turned out positive, you'd think about other differential diagnoses. For example, multicentric Castleman's disease. So it's basically someone who is HIV positive, immune suppressed. They get generalized lymphadenopathy due to human herpes virus 8. So that's important. But this patient, it was just purely TB. Now with TB, which is quite disseminated, and even they biopsied, and they found actually there was pus, then you have to stop and think, what's going on? Now, an important finding is that you find that the patient was also having significant cerebral atrophy. Now, a 28-year-old male, not drinking alcohol, having significant cerebral atrophy, and then also having very severe TB, then you have to stop and think of perhaps immune deficiency syndrome. And there's one that actually links susceptibility to TB and cerebral atrophy. This is called STAT1 gain of function mutation. So these people have a problem with the interferon gamma pathway, but then they also get microcephaly. Sometimes they also get cerebral atrophy before microcephaly. So that one can happen. But then also there's some people who have something called Mendelian susceptibility to mycobacterium disease. And these people basically have, again, a problem with interferon gamma, signifying the importance of the macrophages in fighting the infection. And therefore, they can just get horrible, severe disease. So it's very important. But by looking at the CT scan itself, you can actually say this person is HIV negative because there's significant scarification, meaning the body put up its best fight in trying to eliminate the disease. And in the process, there is damage, and that's why the lungs looked really bad. Unfortunately, I don't know how long he will survive because it seems he has significant disease burden. But just as a take home, if the HIV test is negative more than once, okay, maybe twice, think outside the box. Again, thank you very much.
Excellent. So the question from Dr. Andrew on the chat is, would you have wanted to keep this patient a bit longer in HDU? The discharge plan seems like a continuation of HDU care at home. Maybe I'll answer that. We unfortunately are seeing quite well, a balance between the need to continue treatment of patients and the financial implications. And we as health workers are going to have to learn to be quite adaptive in the way we care for them, including being able to set up a home care kind of arrangement. At least in our practice at TMR, we have been able to set up to ICU level care for patients in a home care setting as a means to cut costs. So patients who need to be on a ventilator much longer but cannot really stay in a hospital for cost-related issues. And again, the risk of transferring them to another place and starting all over again might be high. Most of these patients are probably candidates for setting up a home care arrangement in which we might be able to get them a ventilator. We might be able to get them a critical care nurse and visiting doctors. Of course, the selection is also important here because you need a patient who is fairly stable with no fluctuations and maybe not so much acuity going on. For this particular patient, they reached a point where they could no longer sustain hospital care. And the question was whether the patient is palliated and allowed to die or given a chance in a setting that the family could manage. So that's where the conversation of possibly taking them home came in. At the moment, I have about 8 patients in the community, 5 of whom are still on a ventilator. Thank you. Any other questions? All right, so kindly let's continue this chat on the chat. Just put in your questions. Maybe Faisal, you mentioned connective tissue disorders involving the lungs, and in brackets said sarcoidosis. Could you explain sarcoidosis in relation to connective tissue disease? Sounds to me like just a chronic granulomatous disease rather than a connective tissue disease? Might you have meant some other connective tissue diseases like maybe a rheumatoid lung? Faisal?
Oh, yes, good evening. In the face of the presentation of a patient who had progressively worsening dyspnea and these numerous admissions and management as pneumonia with improvement and then recurrence of symptoms, I was possibly thinking of maybe the possibility of an underlying chronic inflammatory process that is contributing to this picture of repeated episodes of dyspnea. And I think given the examination findings, how the patient looked quite sick, and I was just throwing up the possibility of the connective tissue disorders that kind of involve the lung and give this restrictive picture of breathing.
Lovely, thank you so much. Yeah, I was just kind of making a slight correction. I don't believe sarcoidosis falls under the category of connective tissue disorders. I stand to be corrected too. I believe it's just one of the granulomatous diseases, but you can just take a look at that. But you're totally right. This patient had a relapsing lung disease, progressive fibrosis, loss of lung volume, and recurrent hospitalizations. Absolutely one of the things to think about. Thank you. All right, so we are well past the time for this conversation, and kindly continue the chat. In the meantime, I would like to introduce our next speaker, Dr. Jonathan Mugenyi, who is an emergency medicine resident. He's going to take us through pathophysiology of restricted lung disease. Doctor, take it away.
Good evening, everyone. I hope I'm audible to you all.
Yes, we can hear you, Doctor.
So my name is Jonathan, and I'm just going to lead you in a brief discussion about the pathophysiology of restrictive lung diseases. As we've seen from the case in our case presentation above. So first, what are they? And they are heterogeneous group of pulmonary disorders, basically meaning they are a wide group of diseases with various pathophysiological mechanisms, but the reason we're grouping them together is what they are all characterized by reduced distensibility of the lungs or impaired lung expansion, which leads to restriction, which gives us the name of the restriction and leads to finally reduced lung volumes. So I found it necessary to include this graphic very early because pulmonary function tests are a very important step in a diagnosis of restrictive lung diseases, and a lot of the terminology you see on this slide will be very important in our understanding of how these different disorders will all lead to restriction and finally hypoventilation and hypoxia in our patients. So, what causes restrictive lung diseases? There are broadly categorized. You could categorize them into intrinsic disorders and extrinsic disorders. So intrinsic disorders are usually primarily pulmonary processes. These are processes that are happening within the alveoli, and usually the inflammatory or fibrotic processes that affect alveoli and affect their ability to expand and distend, and also maybe increase their ability to recoil back into shape, which will affect how much a patient will take in oxygen. They could also be extrinsic disorders, which are more physical impediments. These are physical and sometimes neuromuscular impediments to the patient that hinder their respiration. And eventually, all these processes have the same outcome of decreased or impaired ventilation in a process, which will eventually progress to respiratory failure and certain complications due to said respiratory failure. So first, we'll look at intrinsic lung diseases, the ones which are primarily pulmonary processes, and they are various in nature. They could come. There are many causes of intrinsic lung diseases, especially the restrictive ones in nature. Some of the images in front of you should just give you a hint of where we're going with our discussion. But just to break them down quick, it could be caused by drugs. Some of the drugs that would common in our setting would be amiodarone. Patients on who are on medications like bleomycin for tumors might also be affected by this. As somebody hinted during our previous presentation, you could have granulomatous causes of intrinsic lung diseases, things like sarcoidosis or hypersensitivity pneumonitis. It could be due to chronic exposure. So that's where we would find our pneumoconiosis, things like silicosis, a farmer's lung, a coal miner's lung. Sometimes we might have an immune process which is affecting our alveoli in the lung, and this is where we have rheumatoid arthritis. We would have someone presenting with bleeding and hematochezia or coughing out blood in good pasture syndrome, patients with SLE, and then there's always the category of the people who come in with idiopathic intrinsic lung diseases. So basically, what happens in almost all of these processes is you're having either inflammation or a dysplastic change in the lungs, but this dysplastic change or thickening or inflammatory process at the alveolar walls is going to create a barrier to gaseous exchange. So it's going to impair lung diffusion or diffusion capacity at the alveolar membrane, and it's going to result in hypoxemia. But why is it resulting in this? Because there is increased stiffness of the lung. We have increased stiffness at the alveolar level. So the alveoli have increased elastic recoil, which means they'll collapse more readily. And when they're collapsing more readily, that means this patient is going to be unable to maintain higher tidal volumes, and which is going to mean a lower alveolar ventilation and worsening hypoxemia. So the worsening of inflammatory processes from the earlier process will cause a reduction in the patient's ability to take in sufficient volumes. So over time, you're going to have pulmonary vasoconstriction as a response to the hypoxemia in those areas of inflammation. And when we have that, it's going to increase pulmonary vascular resistance. And this resistance is going to be transmitted all the way down to the right ventricle. So you'll have impaired right ventricular emptying, and you'll have a rise in central venous pressure. And over time, a patient with this type of resistance will be at a high risk of developing right-sided heart failure. And that is what happens in the intrinsic pulmonary restriction. There are also extrinsic causes of this restrictive lung disease. As you can see in the images there's a patient the patient with a spinal issue who is in traction, and somebody who is quite overweight. And these are very important because away from the primary alveolar processes, the lungs exist as part of another system, a mechanical system. And anything that affects that mechanical system is going to affect the ability of those lungs to expand within the cavity they are in. And anything that affects that is going to cause an extrinsic, or is going to be an extrinsic cause of restrictive pathology. So the first one is the respiratory center, simply because the force that is needed for the respiratory pump, the chest wall to go up and down for the diaphragm, and the chest wall to go forward, is going to all come from the respiratory center. You could have chest wall abnormalities that are going to affect the ability of this same chest wall to expand. Things like scoliosis, pectus, as we will see a bit later. Intrathoracic space occupying lesions like tumors may affect the mechanics of breathing. However, many tumors in that region actually present very benign or until later on. But certain lesions or tumors like breast cancer, which may be invasive, might affect the ability of the chest wall to expand. Neuromuscular dysfunction may present locally or as a result of what's happening in the respiratory center. And then the effect of abdominal distension or obesity, as you can see in this image, is something that as patients who manage critical care, is something we need to be mindful of, because the effect of intra-abdominal pressure on the mechanics of breathing is quite significant. And the sicker the patient is, the more we have to factor this in, especially if we're having a breathing challenge. So about the respiratory pump, it has certain components. We know that's usually the muscles, the nerves, and the most important muscle of those being the diaphragm. So these are the different areas that extrinsic causes of restrictive pathology would affect. So anything affecting our rib cage, the sternum, the vertebral column, our diaphragm, and our intercostal muscles is going to have an effect on the mechanics of breathing. Flexion and extension of the spine alone can account for up to 50% of the vital capacity. This is more important in a patient with pathology because it is going to affect the ability of the lungs to expand, and even sometimes the cavity into which they expand to. So basically, all these extrinsic factors of how will they cause restriction? They will affect the chest wall compliance. So if the chest wall externally is non-compliant, then there's a limit to how much the lungs themselves will expand. So when you have limited expansion of the lungs, you have hypoinflation, you have hypoventilation, and because of that increased stiffness of the lungs, you have decreased total lung capacity. So this patient is going to hypoventilate due to these other conditions that are affecting the mechanics of breathing according to their different pathologies. This is just an image which is just to show you the effect of the anatomy on the chest wall, or the effect of anatomy on the mechanics of breathing. As you can see, there is a there's decreased space for this patient's lungs to actually expand into. And naturally, this patient will have a decreased total lung capacity. And this is just one example of what can happen there. And an important thing to recall is the innervation of our chest wall and how it can be affected in different ways. When you remember that you have 12 pairs of thoracic spinal nerves, it highlights the effects that something like trauma to the spine or to the chest wall can have to the mechanics of breathing, because these are the same nerves and muscles which will be involved in the mechanics of moving the chest wall up and down, or expanding the chest wall during normal ventilation. So neuromuscular dysfunction, as we saw earlier, it could be at different levels. But the most important thing is when you have impaired contraction, we'll have limited excursion of the chest wall, so we'll have reduced lung expansion. And this could be as broad as trauma or something like ALS, myasthenia gravis, GVS. But the most important takeaway of all of this is spirometry is the most common way of diagnosing restrictive pathology. However, it only suggests a restrictive defect, and usually lung volumes, total lung capacity, is the gold standard. Usually, after you've done your spirometry and you suspect a restrictive pathology, an HRCT is usually recommended to know the specific cause, as you saw in the patient in the presentation before. The total lung capacity in all restrictive pathologies is decreased. Post-vital capacity, because of lower volumes, will also be reduced, but you have a preservation of the FEV to FVC ratio. Finally, I just wanted to mention the diffusing capacity of carbon monoxide. So because we are having an intra-alveolar process that is affecting diffusion and causing hypoxemia, usually if in a setting that has the ability to, the rate at which carbon monoxide diffuses across these membranes can be used as a proxy to differentiate between if you have intrinsic or extrinsic lung pathology, because the speed at which you have the diffusion of carbon monoxide will not be affected if the lung parenchyma is normal. So where this is available, it is the best way to, or a very useful way to differentiate between extrinsic and intrinsic lung pathology. So in summary, we have multiple causes of these restrictive lung pathologies. They could be extrinsic or intrinsic. They could happen at very many levels. But the important thing to remember is all of them lead to a decrease in our total lung capacity, our vital capacity. They'll lead to hypoventilation, and eventually they're going to lead to hypoxemia and respiratory failure. Thank you for your attention. Those are my references.
Excellent, excellent. Thank you so much, Dr. Mugenyi. Questions, put your hands up and ask. I haven't seen questions on the chat for this particular one. Okay, so in the absence of questions from the audience, I'm happy to pick on people and just make life hard for now. Sophia Menya, what's the DLCO in alveolar hemorrhage? Elevated, normal, or decreased? Having listened to the talk, Sophia, or is just the avatar that is connected for now? Okay, Gerald Niringie, what would the DLCO be in a setting of alveolar hemorrhage? Elevated, decreased, normal? Okay, I'm getting quite a lot of silent treatment at the moment. And hopefully we'll get, oh yeah, Zahra said it's decreased. Zahra Abdi, could you unmute and explain? The bit of it is also binary, so I see so many answers coming up. Sophia Namubri says it's increased. Semakula Patrick says it's reduced, okay?
Compress the heart.
Okay.
Get it.
Hello.
Let's say for that, we wait. Get a point to see what but now we don't have any specific reasons why we scan. But if we need to do a scan of the brain,
Apologies, I was retired briefly by the internet connectivity. Did I get the answer, Patrick? Quick one. Why do you see the DLCO is decreased? Patrick Samakula? Dr. Peter Gaba, maybe you can just explain, sir. I saw you said it's increased. Kindly unmute.
No one is unmuting today.
Okay, kindly unmute and tell us, why do you say DLCO is elevated in pulmonary hemorrhage?
Well, increased hemoglobin in the alveolar. So it's going to be, the hemoglobin is going to bind the carbon monoxide. I think that's mostly it. There are other things, but I think that's mostly it.
Excellent, excellent. So I hope everyone notes it down. Everyone kindly make sure that these pulmonary function tests are at the fingertips, because at the end of the day, the moment you say you treat people with lung issues, you must know them and they expect to know them. So, all right, so quickly to the next speaker, Dr. Caesar Owor is an anesthesia resident at the Department of Anesthesia and Critical Care at Makerere University. He's going to take us through the physiological approach to therapy for patients with restrictive lung disease. So over to you, Doctor. Kindly share your slides and start.
Hello. Good evening, ladies and gentlemen. Owor Jesse is my name. I'll be taking you through a physiological approach to therapeutics. Am I loud and clear?
Yes, you are.
Very clear.
Okay, so like Jonathan preempted earlier, restrictive lung diseases are a diverse group of disorders, could be extrinsic or intrinsic, and they're characterized by reduced distensibility of the lungs, compromising lung expansion, and in turn reducing lung volumes. They account for about 20% of pulmonary syndromes. There are quite a number of causes, like Jonathan pointed out. What I can note is that extrinsic restrictive lung disease is due to pathologies that produce either decreased muscle tone of the respiratory pump, such as neurological deficits, Guillain-Barré syndrome, ALS, and the like, or deformations of the rib cage, or even space-occupying lesions within the chest, such as pleural effusions and pneumothorax. On the other hand, interstitial intrinsic causes of restrictive lung disease, they are equally heterogeneous. Some are idiopathic, some are secondary to other problems, like Jonathan pointed out. And they are characterized by inflammatory changes involving the alveolar interstitium with possible involvement of bronchial structures. They vary from occasional self-limited inflammatory processes like exposure pneumonitis, such as hypersensitivity pneumonitis, e.g. farmer's lung, severe debilitating fibrosis of the lungs, which is sometimes progressive, such as in idiopathic pulmonary fibrosis. The causes are diverse, including some medications, inorganic dust exposures, silicosis, asbestosis, and the like. So what happens in intrinsic restrictive lung disease, which are mostly grouped as, or broadly known as interstitial lung diseases, is that we have structural and anatomical alterations resulting in profound changes in the mechanics of breathing. The extracellular matrix of the lung is made up of an interplay of proteins such as collagen, elastin, proteoglycans, and fibronectin. But in interstitial lung diseases, you have a dysregulation of this balance. So you end up with increased deposition of collagen and elastin. Elastin is very elastic. It's responsible for almost entirely for the elastic recoil of the lung. On the other hand, collagen can only stretch to about 1 to 2% of its original strength or original length. And at baseline, the collagen fibers actually exist in what I would call a folded structure. So that by the time they are stretching, the lung is reaching its maximum capacity. So in interstitial lung diseases, collagen fibers accumulate around fibroblastic foci, hence causing stiffening of the corresponding regions. With histopathological hallmarks being things like spatial heterogeneity, where you have should I call it a mixture of normal lung together with slightly altered lung, or temporal heterogeneity, where you have a mixture of slightly altered lung with densely fibrotic regions. Or it could be a honeycomb structure, where you have dilated air spaces lined with epithelium. So with all these changes, the lung becomes stiff, difficult to distend. So what happens is the patient, or what we call low compliance, hence a restrictive pattern. So what happens is the patient actually has to work hard to breathe in, hence hypoventilation, and they end up with hypoxemia. With hypoxemia comes things like difficulty in breathing, exercise intolerance, tachypnea, respiratory muscle wasting because the patient is working hard to breathe. And then in cases where the alveoli are aligned with the epithelial tissue, you end up with a diffusion defect, and patients have chronic hypercapnia. All this culminates in pulmonary hypertension due to multiple mechanisms, including pulmonary hypoxic pulmonary vasoconstriction, vascular remodeling, vascular pruning, and the like. With pulmonary hypertension, the patient ends up with a right heart failure in progressive disease. So this graph here demonstrates the relationship between the stress the lung is exposed to, i.e. the pressure that the lung is exposed to distend it, and the strain, how much the lung will expand. In normal lung, the relationship is less steep, okay? Because, well, the lung will distend forever, not forever. Compared to fibrotic lung, where the relationship is actually very steep. Where is my arrow? The relationship is very steep due to increased deposition of collagen. So the lung actually reaches maximum distension so fast, and the hands squeezing a ball, we shall come to that when we're discussing mechanical ventilation. So with the understanding of the physiological changes in interstitial lung diseases, this guides the therapy. So our aims will be to reduce inflammation and slow disease progression, to improve lung mechanics, optimize gas exchange, reduce work of breathing, treat underlying conditions or secondary conditions that will arise in due course of the illness, and also improve respiratory muscle strength, because we know over time, due to working too hard to breathe, the patient gets wasting of not only respiratory muscles, but including peripheral muscles, and malnutrition due to poor oral intake. So to reduce inflammation and disease progression, the treatment will depend on the cause. If the illness is related to exposure, as in the cases of drug-induced interstitial lung disease, organic dust exposure, or even hypersensitivity pneumonitis as seen in some farmers, then the treatment is going to be avoid the exposure. And some of these illnesses will reverse if the exposure is stopped, and if the illness is caught early, some of the changes will reverse, and some patients will need the course of steroids. In diseases which are not exposure related, such as sarcoidosis, or cases where you're occurring idiopathic pulmonary fibrosis, then you're going to attempt a course of corticosteroids. If the patient improves, chances are high that could be one of the granulomatous illnesses or even autoimmune illnesses like rheumatoid arthritis, Goodpasture syndrome, and the like. If the patient doesn't improve, it is likely that it's a refractory idiopathic pulmonary fibrosis, and they may benefit from antifibrotic agents such as pirfenidone and nintedanib. Some of these are a bridge to lung transplant because idiopathic pulmonary fibrosis is actually a progressive illness. In addition to all this, you have to be alert and treat, prevent bacterial infections and acute exacerbations of a patient of known interstitial lung disease. So patients will have to get vaccinated against illnesses such as strep pneumonia, viral infections such as influenza, COVID-19, and the like. Some interstitial lung diseases are secondary to smoking. Cessation of smoking has to be a prime goal in treatment of these patients. So our second aim will be to improve lung mechanics and function. So of course, steroids slow disease progress, and in some patients, they actually induce remission. So the lung will go back to nearly normal function. Antifibrotic agents also slow down progression in cases of idiopathic pulmonary fibrosis. So in a way, they contribute to improved lung mechanics and function. Pulmonary rehabilitation involves exercise training, educating the patient. So patients undergo endurance exercise and resisting or strength training, breathing exercises. All these have the aim of building muscle strength, improve muscle utilization of oxygen, and also improve the patient's endurance. The long-term goal is to improve quality of life, reduce work of breathing, and reduce the feeling of dyspnea. Then, of course, lung transplant. Well, if you get a new lung, usually it will be a good lung. Yeah, so another aim in treatment of interstitial lung disease or intrinsic causes of restricted lung disease is actually to optimize gas exchange. This goes in hand with improving work of breathing and alveolar ventilation. Okay, so depending on how the patient will present to you, supplemental oxygen by way of nasal prongs or home NIV is actually helpful in improving quality of life. May it improve mortality, it improve cardiovascular morbidity, progression to pulmonary hypertension and right heart failure. It will improve exercise capacity of the patient and will also reduce frequency of hospitalization. On the other hand, high flow nasal oxygen is actually helpful in the acute phase. If a patient presents to you acutely with acute hypoxemic respiratory failure, high flow nasal oxygen provides high flow humidified oxygen, reducing dead space, improving oxygenation. It does offer some positive end expiratory pressure, which can help recruit alveoli and reduce the work of breathing. And in very sick patients, it is better tolerated than non-invasive ventilation because it's more comfortable. And it does reduce need for intubation. And some studies have demonstrated that it improves short-term survival compared to NIV, but there are some methodological limitations in those studies. Issues of blinding and the choice of therapy was left to the physician. So that we can take with a bit of whatever. Yeah. Non-invasive ventilation is indicated in again acute hypoxic respiratory failure, but it can also be used for patients with extrinsic lung disease, extrinsic restrictive lung disease such as neuromuscular disorders or chest wall deformities. Patients of this kind could benefit from home non-invasive ventilation, especially if they present with evidence of respiratory decline during the course of their illness. Signs such as sleep disturbances, nocturnal hypoventilation, daytime symptoms, orthopnea, and morning headaches. So NIV does improve quality of life. It reduces symptoms of difficulty in breathing, improves work of breathing, and of course improves alveolar ventilation. Invasive mechanical ventilation is unfortunately patients will need or might need invasive mechanical ventilation, but it is associated with a very high mortality in up to 90% in some studies. So we shall call to mind the graph I shared earlier, where because of the intermix of fibrotic tissue together with normal tissue, when you ventilate this patient, the normal tissue will distend. So normal tissue will distend, but it will start to squeeze through the fibrotic tissue, okay? Hence increasing chances of ventilator-induced lung injury, even at low pressures. So indeed, you would consider invasive mechanical ventilation, but you might find that it is more beneficial as a bridge to lung transplant, given that the traditional approach where we use high PEEP, for example, in patients of acute respiratory distress syndrome, may actually worsen lung mechanics and increase the risk of barotrauma. So the approach would be to use low tidal volumes, about 6 mL per kg of predicted body weight, and limit the plateau pressure to under 30 centimeters of water. Avoid high PEEP by all means, because it is not appropriate given these mechanical changes. So our aim we may have to adjust our aim and tolerate moderate atelectasis, titrating PEEP to just minimal values necessary to achieve oxygenation, minimal oxygenation, i.e. an arterial partial pressure of oxygen above 50 to 60 millimeters of mercury, or an SpO2 above 88 to 90%. Prone positioning is generally not beneficial in fibrotic lung unless you can demonstrate that the acute exacerbation is due to a reversible cause, such as a superimposed pneumonia and the like. So this table demonstrates what I was talking about. This is from a case report of 3 patients who two of them had chronic hypersensitivity pneumonitis, and the 3rd patient had intrinsic pulmonary fibrosis. If you notice that these exact patients were subjected to a low PEEP setting and a high PEEP setting later on in their care, while monitoring certain mechanical properties of the lungs. Notice that using a low PEEP still achieved a good driving pressure, still achieved fairly equal arterial oxygenation, okay, or rather clinically relevant really, but using a high PEEP on the other hand affected the respiratory mechanics. So the lung had a higher tendency to collapse, as demonstrated by the measurement of high elastance values in all the 3 patients when we used a high PEEP. This of course is informed by the strategy usually employed in acute respiratory distress syndrome, where a high PEEP keeps the lung open, hence reducing ventilator-associated lung injury due to continuous closure and opening of alveoli. But in interstitial lung disease, it is more beneficial to use just enough PEEP to achieve a minimal arterial oxygenation. Then, of course, finally, treat the underlying conditions as we mentioned them. Pulmonary hypertension, some of these patients will benefit from phosphodiesterase inhibitors or endothelin receptor antagonists. Treat right-sided heart failure, nutritional rehabilitation to improve muscle strength, and PPI to prevent complications of aspiration, given that some of these patients end up with gastroesophageal reflux disease. For extrinsic restrictive lung, the approach will largely be the same in terms of optimizing gas exchange, improving lung mechanics, but they will also benefit from treating the particular cause. If it's pleural conditions such as effusions, pleural scarring, chronic empyema, or asbestosis, treat the cause. For neuromuscular disorders like muscular dystrophy, ALS, and phrenic neuropathies, these might benefit from home NIV. Obesity, weight loss is emphasized, and then of course relieving abdominal compartment syndromes as they arise. Thank you very much.
Excellent. Worry. This is unfortunately a depressing talk. You're just basically telling us as little we can do. We're used to our gadgets and making miracles happen with those gadgets. But it looks like their utility is limited. And so the patient might as well just avoid getting onto a ventilator at some point. So I'd like to welcome questions from everyone. Dr. Worry is right here to answer them. So I guess I need just you to clarify the statement you made was that that mechanical ventilation is associated with the increased mortality in these patients. I wanted to be clear whether it is mechanical ventilation that is bad, or it is that the patients who require mechanical ventilation who are too sick to even benefit from mechanical ventilation. I want to just be clear. As no Dr. Pucha said, Dr. Joyce will talk about the next talk, but what is your position?
My position is that, well, indeed, the patients are too sick and the illness is actually progressive. I don't know.
No, absolutely. I think I like the answer already. I like the answer because it's key to understand that we are dealing more with the disease itself that is progressive and probably just going to be quite crazy. But I just need your thoughts on how to play with that ventilator. I don't know if Dr. Joyce will add on later on. How do you play with that ventilator apart from just the general remarks you've shared with us? How do you play with that ventilator in terms of, just keeping that patient alive on the vent? Doc?
As in the general approach to setting the ventilator?
Yes.
For a patient
Yes. I don't know if it's my network or it's yours. I lost you there, Dr. Or. Okay, so we have a comment from Tony Sempereza who says IMV is not curative and the risk of hemodynamic complication like increased thoracic pressure and ventilator-associated hypotension. Could this count, given the patients are already too sick, as a reason for possible non-beneficial nature of mechanical ventilation? All right, so quite great comments. I guess, Dr. Preach, I would like to get your comment here. If you ever had to put a patient with, restrictive lung disease on a vent, how would you approach the care of such patients?
Thank you very much for that question. So I would approach it in terms of extrinsic and intrinsic causes of restrictive lung diseases. This week I had a patient, a 93-year-old patient with recurrent sigmoid volvulus. And this time when I went to see him, he was peri-arrest, but he had the classic abdominal compartment syndrome. I've never seen such a big, tense abdomen. And basically, apart from preventing the blood supply to the brain by causing the IVC to be collapsed and also the aorta, basically the diaphragm is splintered. So in such a patient, if we have a way out in terms of, okay, we are going to go to theater, we're going to do a sigmoidoscopy or a laparotomy, then I would be very much inclined to do mechanical ventilation, and I'll already know the peak pressure will be high, the plateau pressure will be high. These lungs are already compressed. So I would perhaps choose to go with more of volume control mode, just giving volume or maybe pressure. But then with intrinsic lung diseases, let's say idiopathic pulmonary fibrosis, it normally causes usual interstitial pneumonia. Now, with usual interstitial pneumonia, the findings on the CT scan is that you have bilateral basal fibrosis. The apices are basically left to be clear. So in such a patient, if I intubate, I know, okay, this person has two parts of the lung, one is fibrotic, one is not. And therefore, I would use a pressure support mode of ventilation to just make sure the lung is well ventilated. Concerning PEEP, I would be very sure to give them a lot of PEEP, some PEEP, especially with mechanical causes, because if the diaphragm is splintered, then there's atelectasis, so you want to keep them open. However, with intrinsic causes, there's already fibrosis. And essentially trying to overdistend these already fibrotic lungs, which are already inflamed, will worsen the lung damage and cause an increased inflammatory milieu and worsen the disease process. Therefore, the approach to the ventilator is either intrinsic or extrinsic. For intrinsic, I would really settle with the pressure mode of ventilation. I'll be very careful with the PEEP. And I would just immediately, as my colleague Joyce will mention, it has a poor prognosis. With the mechanical causes, if we have a way out, let's say someone has post-TB lung disease, pleural fibrosis, and they basically need decortication, then, okay, you could play around maybe with volume or pressure, whichever you want, so long as there's an output, there's a way out in terms of the management strategy to reverse the condition. Thank you.
And what are your endpoints?
So my endpoint, my endpoint in terms of ventilation, are you speaking about looking at ABG or general management?
Yes, general, when you're managing them, including ABG, what will be your goals when you're caring for these guys?
Okay, so these people have restrictive. So for the intrinsic people who already have bad lungs, I would manage them as ARDS. So basically, low tidal volume, 4 to 6 mils per kg, ideal body weight, plateau pressure less than 30 centimeters of water, driving pressure less than 15, maybe permissive hypercapnia, although they already have hypercapnia because of reduced diffusion capacity of oxygen and increased shunt fraction. So I'll just use the ARDS pattern for management. For the mechanical restrictive, for the extrinsic causes of restrictive lung disease, well, I'll just manage them as any other pneumonic process. Of course, maybe low tidal volume because the lungs cannot really expand, and if you try to overventilate them, it may not work. Concerning the ABG, I may just target maybe normal ABG, so long as it is not a chronic condition. If someone comes in with kyphoscoliosis with very poor inspiration and all, meaning the ventilation their intrinsic ventilation is very low. Therefore, they retain carbon dioxide. Therefore, also for them, I would give them a permissive hypercapnia. For obesity hypoventilation syndrome, again, they have aspiration causing fibrosis. They have significant abdominal fat causing splinting of the diaphragm. They have very big chests causing reduced compliance. For them, I would also use protective lung ventilation strategy. So protective lung ventilation strategy is a safer way if you're stuck with a restrictive lung disease. Thank you.
All right. So I guess I guess what you're telling us is really about West Lung Zone 4. That's the baby lung, the lung that retains its physiological characteristics and the beauty of preserving it, with the hope that it helps you fight back if, especially when the cause of the exacerbation actually is it's an unrelated issue, maybe maybe a new infection or something reversible, maybe a PE or something like that. So you want to protect the lung. Yeah, so excellently put. So now we would like to move to the next talk. Dr. Joyce Kalunji is an anesthesiologist and intensivist training out of UBC in Canada, and she is going to take us through the advanced interventions in restrictive lung diseases. So kindly give her the attention. Let the chat continue on the chat room. Thank you. Dr. Joyce, over to you.
Thank you so much, Dr. Erasmus. Can you guys hear me very well?
Yes, we can clearly hear you.
Okay. Yeah, if at any one point I kind of wavy with the internet or you cannot hear me, you can send me a text on WhatsApp. So yes, as you've said, I'll talk about advanced interventions in restrictive lung disease. I think the major objectives, the topic was quite big. I'm glad that my colleagues have gone through most of the stuff, so I hope to strictly summarize, but it's just to understand the management of acute respiratory failure in interstitial lung diseases, in neuromuscular diseases. Yeah, we'll talk briefly on surgical management of restrictive lung diseases and home ventilation, because I was told to talk about it, and maybe we'll go through 2 or 3 cases. So I think the classification of restrictive lung diseases has been done, and I will not go through that. They affect pleura, alveolar, interstitium, neuromuscular, and thoracic cage, and they're basically characterized by reduced total lung volume. And yes, I'll not go through that. So approaching this from an intensive care perspective, usually as intensivists, we deal with acute respiratory failure, and people can come to us with acute respiratory failure either because they have pleural disease, which is pre-existing, or acute, or they have alveolar interstitial lung disease, or have neuromuscular diseases. And it's also not uncommon to have, in fact, patients with thoracic abnormalities, kyphosis, scoliosis, obesity can still come to us. So the talk mainly focused on either acute exacerbation of the disease or an acute presentation of the disease. So interstitial lung disease has been the major topic of discussion today. And all my colleagues have said that the disease is heterogeneous. So, and we cannot emphasize this more. If a doctor treats what they don't understand, it means the patient is in trouble. So it's this, what we call interstitial lung disease is basically a syndrome at first, characterized by inflammation and fibrosis, but it covers over 200 entities. So there are a bazillion things that can cause what is called interstitial lung disease. The diagnosis is difficult to make, and the consensus is not clear among different societies. So it's basically a clinical, it's a clinical diagnosis, as well as a radiologic diagnosis, a histologic diagnosis, and a serologic diagnosis. So you need to be able to take a very clear history, look under the table, and look at every single thing to be able to understand the chronology of events. You need to have very good radiologic investigations, histologic investigations, and serologic investigations. So as an intensivist, you're going to be faced by 2 types of patients who will have interstitial lung disease. You'll have the acute type of interstitial lung disease, or de novo, someone has been well in the community, they've not been known to have any other disease. This disease is then rapidly progressing. They get symptoms within a month, they are in hospital. So there are sort of various types of interstitial lung disease. There is acute interstitial pneumonitis, which is basically you have signs of interstitial pneumonitis, which is basically ground glass, and you can't find out what's wrong. COPD, COP, not COD, should be cryptogenic organizing pneumonia, which is basically a histologic diagnosis. You rule out an infection and you have fibroblasts on a biopsy. Then you have acute eosinophilic pneumonia, which is basically you do a BAL and you have 25% of eosinophils. Drug-induced interstitial lung disease means there is an exposure, and when that exposure is taken away, an exposure which brings symptoms, when the exposure is taken away, the symptoms resolve. And then you can also have diffuse alveolar hemorrhage with vasculitis. Now, I'm not splitting hairs here. I'm just trying to say people look at a CT and they're like, oh, this is interstitial lung disease. But if you don't know that type, you can't manage it. And as we've seen, most of the advanced interventions that we do are useless. So the most important thing is to accurately understand the diagnosis so you can treat the diagnosis. And then there are other types of patients who are possibly the acute or chronic, just like the patients we discussed today. A patient has been unwell, they've been having relapsing symptoms, they have some form of chronic dyspnea that then because of one issue or another, they come into the hospital with an acute exacerbation. Now, because most of these chronic interstitial lung diseases, especially the idiopathic pulmonary fibrosis, have very poor prognosis, it is always important to rule out a treatable cause. Is this an infection? Is it an infection? Is it PE? Is it pulmonary edema? So that you can treat that and not prognosticate the patient. So like I said, you have to pay very close history to the very close attention to the clinical, radiologic, and histologic picture. So interstitial lung disease as a continuum again moves from one part where it's idiopathic, and we've listed the idiopathic lung diseases, and then there are the connective tissue diseases, which seem to have a better prognosis, especially systemic sclerosis. They are steroid responsive and they also respond to immunosuppressants. So it's always important, like when you diagnose a patient either acutely with a diagnosis of acute interstitial lung disease or with an acute exacerbation, if the diagnosis was not clear, to have serologic tests sent off. A rheumatoid arthritis is particularly one of the congenital connective tissue diseases that's associated with interstitial lung disease and always has acute exacerbations. Then there are environmental exposures that may be drug toxicity, occupations, environmental. There's so many drugs that we use, including antibiotics, that are actually associated with some form of interstitial lung disease. So yeah, for instance, if the patient is on amiodarone, they have interstitial lung disease, they continue with that, and they're never going to improve. Then there's sarcoidosis, which is also very steroid responsive. And then there are other Langerhans, histiocytosis, eosinophilic pneumonia, neurofibromatosis. So these diagnoses are very particular. This disease, especially in the chronic stage, is a disease of a multi-system. Many physicians, like immunologists, rheumatologists, and pulmonologists. Basically, the patient should be intervened on before they get to us, especially if it's a chronic interstitial lung disease. Because the minute they get to us in an acute exacerbation, things are going to spiral, as most of my colleagues have been saying. So this table just gives you a clue on how complicated it is to make this diagnosis. For instance, if you look at what is the worst, the interstitial lung disease with the worst prognosis, which is idiopathic pulmonary fibrosis. Usually, the onset, it's chronic. and it will have relapsing symptoms. It's quite common in smokers. About 2/3 of them are smokers. If you look at the CT scan, and I'll show you a sample of that, they're usually peripheral subpleural ground glass opacities affecting again the subpleural and bibasilar, and they are associated with traction bronchiectasis and honeycombing. So this is, the radiologist has to be so good to point this out to the intensivist, so that they, right from the start, they know that this is an interstitial lung disease. And then usually what is called an acute on chronic is someone has been at baseline, the CT looks a certain way, and they get more ground glass. So if they get more ground glass and they've had symptoms of worsening symptoms of dyspnea in a month's time, you'd call that an sort of an acute on chronic. So an acute on chronic would be called worsening dyspnea with worsening ground glass or opacities on the CT. And then there's a histologic diagnosis as well for the histologic diagnosis sometimes come in. So the problem with idiopathic pulmonary fibrosis is most of the times it will have the UIP pattern, which is an unusual interstitial pattern on the CT, but you can also find the non-specific interstitial pattern on the CT. The connective tissue disease, like the ILD, is associated with the NSIP pattern, but not all the time. It's not completely sensitive for that type of pattern. So this is what makes the diagnosis very complicated, because we are relying on radiologists, we are relying on pathologists to make the diagnosis for us, especially if the history we took is not good, or is, and the clinical examination is also not good. Also, I would encourage people to kind of examine patients. First, if a patient comes in with signs with ground glass appearance, and ground glass can be caused by anything from infections, like acute infections, pulmonary edema, aspiration, all those cause ground glass appearance on the CT, diffuse alveolar hemorrhage, all those cause ground glass appearance on a CT. So, but just examining the patient and looking, like, do they have finger clubbing? Do they have a very raised hemoglobin, speaking to signs of chronic hypoxia? Do they have signs of pulmonary hypertension? All these are in keeping, although at the stage of pulmonary hypertension, the disease is really advanced. I've spent so much time on talking about the diagnosis, particularly because it is so important. If a patient is just labeled interstitial lung disease, then we are hugely in trouble. So when you look at this patient actually had IPF, idiopathic pulmonary fibrosis, and you can see like the UIP pattern is usually asymmetrical, heterogeneous, mainly affecting the subpleural and bibasilar predominance, and there is honeycombing and traction bronchiectasis. Yeah, I'm not just splitting at hairs. You guys are not so bored. So if a patient comes to us with an acute exacerbation, meaning they are known to have chronic interstitial lung disease, now they're having acute respiratory failure, the most important thing is to identify what the contributing factors are. You have to dig deep and sort of do thorough workup to understand, is this just an exacerbation of the disease? So the patient, in other words, is worsening, or is there a cause of this acute exacerbation? Because a patient who has an acute exacerbation, if you treat the underlying cause, you'll be able to win them off the ventilator, and that would be a good prognosis. But if this episode is just an exacerbation or worsening of their disease, means that disease has progressed, especially in IPF, that's a very poor prognosis. So you basically should rule out a PE with a CTA, you should rule out heart failure, you should rule out infection, and this includes all the markers of infection, a CBC, a CRP. This may sound a bit controversial, but a BAL, bronchoalveolar lavage is necessary, and if the patient has been on immunosuppressants, because maybe they have a connective tissue disease, then you should manage them investigate for other things that can cause a pneumonia and an immunosuppressed patient. So PJP and all those wonderful things. The viruses are also very good at causing worsening ground glass. So rule out other things as well. Pneumothorax, is this a drug induced? Are there any drugs that are causing this? Is this diffuse alveolar hemorrhage? Because they're prone to have capillarities and things like that. Yeah, and the same thing. So for patients who come in with a de novo episode, in other words, a patient just comes in with acute respiratory failure, you look at the CT scan, it is highly suggestive of an interstitial lung disease. Then you have to look into the history and see how have they been at baseline? Is this new? Have they been having symptoms? What does their clinical picture look like? Do they have any signs of connective tissue disease like rheumatoid arthritis, Sjogren's, or things like that? Evidently, it's very important to send off an autoimmune panel and to do bronchoscopy, do an infectious workup, but also to be able to get biopsies. Yeah, and in the same thing still applies. You should look for a risk factor for the cause. Is it an infection? Is it pulmonary edema? Is it a drug or things like that? So in terms of management, all the things that I'm going to suggest are mainly expert opinion. I've not put in how evidence should be graded, but it's basically expert opinion. So you can take everything I say with a grain of salt. The diagnosis is difficult to make, as I've said. So in most cases, we are doing trial and error because we may not specifically understand what we are treating. Yeah, and the disease is basically heterogeneous, and that makes things complicated. So in terms of pharmacotherapy, people have said this, steroids are mainly good for cryptogenic organizing pneumonia and acute eosinophilic pneumonia. And basically, we usually, you can use either pred or prednisolone, usually started at 1 milligram per kg as a loading dose. Other connective tissue ILD and sarcoidosis are also relatively steroid responsive. So the antifibrinolytics, which are pirfenidone and nintedanib, I think are the ones that have been studied well. Basically, good they don't improve mortality benefit, but they've shown to slow down the progression of the disease. Yeah, immunosuppressants like cyclophosphamide, azathioprine, and all the wonderful things can work, especially with connective tissue disease, but have no benefit in IPF. And then a combination of steroid and immunosuppressants basically increases mortality. In terms of oxygen, we've talked about this, and I think many people have talked about this, and this should be common sense by now. Oxygen therapy is not curative, so it's just basically either to you give it to get the patient through because you're treating the acute exacerbation. If this is just disease progression, like for instance, they have IPF and the disease is just progressing, then we are in trouble. It means everything we'll do will not work. So just like it says on the slide, you can use high nasal flow. There's no mortality benefit. Usually treat the underlying cause. It's a bridge to transplant. You can use it to avoid intubation and for comfort. Again, take this quote unquote, it truly depends on what you're treating. NIV, in these terms, CPAP, still the same thing. For connective tissue disease, acute exacerbations in ILD, you can try it and give steroids, and that means, if when the patient improves, you've actually treated with steroids. Yeah, for invasive mechanical ventilation, the in-hospital mortality is documented as 90%. Again, I think the patients are sick and they are prone to ventilator-induced lung injury. Yeah, the most important thing is if this again is it's just as a marker of disease progression, it doesn't matter what ventilatory mode you use. But if you put if the patient has an acute pneumonia and that's the cause of the the acute respiratory failure, then if you treat the pneumonia, if you treat the aspiration, they'll improve. Inhaled vasodilators like nitric oxide, there's no evidence to use these patients, to use these agents, but we can infer from, I guess, the literature in ARDS. Yeah, so refractory hypoxemia, in my opinion, they can probably prevent you from, going up on your PIPs and causing more ventilator-associated injury. And then also they can help out if you have pulmonary hypertension and you have RV failure. But otherwise, they don't offer mortality benefits. I think they would be beneficial if you use them exactly the way they are used in ARDS. ECMO is basically a bridge. It's a bridge to transplant. You ideally should have either you have a reversible cause like a pneumonia, or it's a bridge to transplant. Someone has to be a transplant candidate for you to use it. There's no difference between doing awake ECMO, because you may be scared to intubate patients with interstitial lung disease, or intubated. I think the study that has been done showed that they randomized, basically it's just a small study of 21 patients, and they were all put on ECMO, 6 got transplants, I think, and then 14 out of 15 people that did not get heart transplant actually died on ECMO. So ECMO is basically a bridge. So in regards to lung transplant, who gets a lung transplant or not, I think the practices are center dependent. Ideally, the transplant should be done electively, especially for patients with idiopathic pulmonary fibrosis. The minute the diagnosis is made, regardless of the pulmonary function tests, that the patient should be put in connection with a pulmonologist and with a transplant team, just to tee them up for that. It can also be, there are some cases in which you can do a salvage transplant. Someone is known to have maybe an interstitial lung disease, they come in with an exacerbation, and if you think you can treat the underlying cause, you can use it as salvage therapy at that time. So it's considered more for fibrotic ILD, and as soon as the diagnosis is made. However, if based on patient frailty and comorbidities, they may not be considered. Connective tissue disease is a little bit more difficult because it's a systemic disease. So you could ideally transplant the lungs, but then if there's still uncontrolled systemic disease, then the patient there may be graft failure, things like that. But again, it's not a contraindication. I think as more transplants will be done, we'll get more information. So the last thing I would like to talk about is advanced directives, especially understanding how lethal the disease may be. So I think before we intubate patients, we ideally should talk to them, or the next of kin, we should talk to them about the prognosis of the disease. If you've understood the pathophysiology, and it should be shared decision making. It should not be just up to the doctor to say, oh, I think you have acute respiratory failure right now, and I should intubate you, because the outcomes may not be as good as we want them, especially with a high in hospital mortality. It's always good to exclude confounders, because if you're able to treat the confounders, then that's good. So I'll briefly talk about neuromuscular disease. If at any one point I'm going on and on, you can stop me halfway if I've used up my time. So the other condition that confirms the restrictive lung disease that usually comes to the ICU is neuromuscular diseases. And usually the ones that come in with acute respiratory failure are usually GBS, spinal cord injury, infections. And then there's the sort of the acute and chronic type that include the ALS, muscular dystrophy, and myasthenia gravis. So it's such a big topic to talk about, but I thought I would just raise like about 3 or 4 points. One, with patients with neuromuscular diseases, especially in our setting, one thing to know is that ABG is not a reliable marker of decompensation. Patients may still have relatively normal stats, so they're just on 4 liters of oxygen, but yet they are failing miserably. So patients with neuromuscular disease, please keep in mind not only to monitor the neuro examination and see how it's progressing. For instance, if the patient has PBS, is it ascending? Do they have facial weakness? Do they have now bulbar symptoms? And the most sensitive marker is, of course, the FVC, and I've put the values there. However, you can do a MIP and an MEP for that. Also, I think the most responsible of this disease is myasthenia gravis, because acute respiratory failure rapidly responds to the anticholinesterase inhibitors, and you can actually use NIV as the anticholinesterase inhibitors kicking. There are roles for steroids, IVIG and flex. You should not do IVIG and flex at the same time, but if you give the IVIG and then flex it out, it doesn't make sense. The IVIG or the flex, unfortunately, does not necessarily improve mortality, but apparently it improves the nadir of the symptoms. Apparently the muscle weakness goes on for a less period of time. I don't know. So yeah, these patients are usually prolonged ventilation in the ICU because it takes a while to recover. So they probably, in most cases, end up trached. The ventilatory strategy, usually the lungs are good. This is just a neuromuscular disease. So I don't care so much about doing lung protective ventilation, because the lungs should be as good as new, or as good as anyone else. Yeah, and for patients who have, for instance, ALS or muscle dystrophy, if they've been in the ICU multiple times, they're probably on invasive ventilation at home, and they keep coming in the ICU with aspirations, then you need to have a goals of care discussion as well with them. So in terms of home ventilation, I talked about this briefly. Usually intensivists sometimes are not involved, should not be involved in home ventilation, but I guess we don't have palliative care teams yet, so we do the home ventilation for patients. So for interstitial lung disease, it would be interesting to keep the patient on a ventilator, yet they are, they're not a transplant candidate, but again, that is a shared decision making. Like if it's within the goals of care of the patient, and next of kin they can afford that, yeah, then go right ahead. But for neuromuscular diseases, especially for ALS and for muscular dystrophy, usually these patients are followed in outpatient clinics by pulmonologists, and they'll train pulmonary function tests every 6 months. And depending on those pulmonary function tests, if people are getting either sleep disordered breathing, then they're initiated on NIV at home, and this is quite easy to do. It's the same thing as we do in obesity with hyperventilation syndrome. So a patient is just given CPAP, and then they sort of follow up on the pulmonary function test. If there's any decline in the pulmonary function test, if the patients are progressively developing bulbar symptoms and chronically aspirating, then yes, it's possible to give them a tracheostomy, suction them, do physiotherapy, and then leave them on non-invasive ventilation. Usually it's good to leave them with a speech valve, especially with ALS. With time they lose their speech, but it's good to leave them just with a speech valve to have be able to interact with family well. So home ventilation again is a multi team sport. You need nurses, you need physiotherapists, you need the doctors that follow up. Yeah, my last slide before the cases, I'm sure you guys are tired, is on surgical management. Surgical management in restrictive lung diseases is basically one, I think, for pleural disease. It's basically decortication for people who may have a trapped lung or chronic empyema, so then we benefit from a decortication. And then in obesity, bariatric surgery. So I'm sorry I rushed through things really fast, but we're kind of running out of time. So I'd like to go through some. I just have 2 cases. We can kind of go through them together. I will do the case, and then kind of unmute and then you guys will tell me what you think. Yeah. So here I have a 68-year-old female who's a non-diabetic, has diabetes mellitus type 2 and has alcohol use disorder. Is on apixaban, which is an anti-10 for chronic AFib. She presents to the hospital with headache and confusion 7 days after a fall. So she's found to have a chronic subdural hematoma. She undergoes a BAHO. Her hospital visit is complicated by UTI and delirium. The patient is started on ciprofloxacin and gradually improves. However, 6 days after the initiation of the ciprofloxacin, you're called to the ward for worsening hypoxemia. You intubate the patient during a code blue. So you do an HRCT, you find ground glass infiltrates, especially in the anterior upper lobe on the left side and in the lingular region. The nurse says she's been spiking high-grade fevers, the CRP is high, she has eosinophilia and a CBC. Because of the eosinophilia, you do a bath, bronchoalveolar lavage, and what you find is basically marked leukocytosis. You send out an infectious disease panel for TB, chlamydia, legionella, basically the typical pneumonias that could give you ground glass, and you find that there's nothing, and your echo is normal. Overtly, the EF is normal, there are no valvulopathies. So what is your differential diagnosis? Do you think this patient aspirated? Do you think they have a hospital-acquired pneumonia? Do you think it's pulmonary edema? Do you think it's hypersensitivity pneumonitis? Someone can unmute.
Chantong, Eddie, I think I have sent you that question.
Can anyone unmute and say, give it a try? Or? Okay. We'll go back to the question. So this patient is started on amoxiclav for a hospital-acquired infection. She's been intubated for about 7 days, but she's a difficult wean from the ventilator. So you repeat a CT scan and it's showing progressive infiltrates in all lobes. You repeat a BAL with a biopsy and you find interstitial lymphocystic infiltrates with eosinophilic granulocytes and a few scattered giant cells. What is the diagnosis? Anyways, I found this case online. I found it very interesting. This patient had acute hypersensitivity pneumonitis due to ciprofloxacin. So I just wanted to demonstrate here, sorry for some of the typos in the presentation, that infiltrates on an extra with acute with the true interstitial lung disease with hypoxemic respiratory failure should always be thoroughly investigated. As Dr. Rasmus says, we should not have captivity with boxing. We should always think outside the box and sort of look at a patient in a more holistic manner. So this patient actually improved after the ciprofloxacin was withdrawn. But so I have just one more case. I have a 76-year-old female with rheumatoid arthritis. She's been known to have interstitial lung disease, basically UIP pattern for 6 years now. She, since for about 10 years now, and she's been stable. We review her pulmonary function tests. She has coronary artery disease. She's been done bypass ×3. She's known to have pulmonary hypertension, and you can see the pressures are 39. She has a dilated RV on her most recent echo, and she's basically with severe tricuspid regurgitation. She's awaiting venous intervention. She's independent at baseline, meaning she's able to do everything well, and her PFTs have been stable. You can see the FEV1 is 2.6. The FEV1 FVC ratio is preserved. The total lung capacity is down to the ideally 6. The DLOC is also down at 60%. but she has no oximetry on a 6-walk test. And she has an advanced order to not intubate, no CPR, and then she's also on some immunosuppressants. So she was admitted 5 days ago with a history of cough, flu, loss of smell. She has some sick contacts. She was found to be COVID positive, and she was admitted to the ward on just 2 liters of oxygen. Her oxygen levels have gradually gone up. So you're called for code blue on the ward after a nurse finds new focal deficits. The patient is reviewed by the stroke team, and they think she's a candidate for TPA, so they call you as the ICU resident. You come to find a patient who's altered with airway compromise, SATSA in the 80s, and she's on high nasal flow at 100. What would you want to do in this case? Would you want to intubate the patient and admit them to the ICU? Do you want to call palliative care? Do you want to have a goals of care discussion with the next of kin? Do you want to change the code status? They're basically a patient who has multiple comorbidities, has ILD that's been stable, has heart disease, valvular heart disease, comes in with an acute exacerbation due to COVID, then gets a stroke. I can pass this back to Dr. Rasmus. I think I'm done. People can think on the question.
Yes, thank you very much, Dr. Joyce. This is a lovely talk and quite thorough too. And especially that it takes us to the deeper ends of the diagnostic Igihaga relevant to the subject of the day. In truth, this tortures many a clinician, including the ranking pulmonologists. Sometimes we are limited in diagnostics and therefore distinguishing between two different entities that look alike may be quite tricky. But I guess also this is like the terminal cancer of pulmonology, dealing with diseases that probably will not necessarily respond to the conventional interventions that we have available to us. And you're likely to suffer a lot of, vicarious traumatization, recurrently holding the conversations of goals of care with the families. So, so back to the chat. Do we have any questions for Dr. Joyce? And kindly, as you ask questions, kindly also answer her questions. Rebecca, would you like to respond to the last question? I see on the chat you said palliative care. Could you give us an explanation for it?
I would think this patient would benefit from palliative care, given that the prognosis of her disease, but also the fact that she has a DNR as well. I would just respect that and give her palliative care.
All right, that's good. Have you, Dr. Joyce, maybe you can just come back on this one. Have you encountered patients who consent to only a proportion or just a part of the DNR order? Like instead of saying, do not attempt resuscitation, they'll say, give me compressions for 2 cycles. Do you encounter such crazy people?
Yes, I have. Like there's some people who say I can get a shock, but I'll not get CPR. Like I can be cardioverted or defibrillated, but I'll not get CPR. Which makes sense. If I have like an arrhythmia, I can get it. Makes sense in some perspective.
I don't agree, Doc. I think CPR is a package, meaning that you either all or nothing. In other words, you cannot consent to just a small proportion of it. If I shock you, that's electrical conversion. Doesn't necessarily mean I've gotten mechanical conversion. And usually mechanical conversion depends on, cardiac compressions, chest compressions. So it just doesn't make sense to me that someone who says don't intubate me says, you can compress my chest. Doesn't make sense. But yeah, I guess it's a complexity of a woke nation. We don't have such problems in Africa. We are more realistic here. So sorry. We've been having some questions on the chat. For example, we've had questions regarding oxygen toxicity in patients with interstitial lung disease. What's your comment, doctor? what will be your concern around oxygen toxicity in the care of these patients?
So for my understanding of what oxygen toxicity is, you must actually be hyperoxic to get oxygen toxicity. So if the patient doesn't need oxygen, then the oxygen should be taken off. I think in this case, the physiology of the hypoxia is quite complex with, you know, maybe VQ mismatch or a combination of shunts and things like that. And then sometimes the interstitial lung disease is evidently complicated by RV failure. So I think, and pulmonary hypertension. So I think I think oxygen toxicity is less likely to happen in these patients, because I think usually the disease is advanced, especially in acute exacerbation. The disease should be advanced, and people want to put them on more oxygen to target a certain to have a certain target, a SAT target or a PaO2 target. So I guess just simply to summarize, oxygen toxicity should occur if you're hyperoxic. So with all due common sense, if the patient doesn't need the oxygen, it should be taken off. But I think as the disease becomes advanced, it's much more difficult to oxygenate them. And that's why they may be on high levels of oxygen.
Excellent. Now, regarding mechanical ventilation in these patients, what is your take about the set, peak flow rates on that ventilator? If you're ventilating that patient, what would you choose? High, low, normal?
The peak flow rate. Dr. Asmas, you want to trick me? The peak flow rate.
Not at all.
The peak flow rate. I am unsure. I'm unsure of what the correct answer is.
Honestly, I'm thinking as well, because I'm just thinking these guys are breathing very fast. They have limited lung capacity. And so they want to drive in the air as quickly as possible because the lung will be recoiling soon. So I imagine I would put these guys on higher peak flow rates so that they can get the titles they need. The good thing is that they don't really have airway flow limitation, as is the case with obstructive lung diseases. So they should be able to handle the peak flow rates without worsening their pulmonary air resistance. So I think that would what we'll do, and probably also target a higher respiratory rate too, to just give them a bit of a better minute ventilation. Of course, cognizing the fact that I also do not want to worsen air trapping. I don't want to worsen pulmonary vascular resistance that could happen with mechanical effects on the lung. So I don't have any questions. Does someone want to unmute and ask Dr. Joyce a question? Dr. Gaba, what do you think? Peter Gaba? Dr. Arthur Mwanje? Oh, by the way, what is your take on pirfenidone, doctor? I think kill our hopes. Kill our hopes. I know that many colleagues practice and use pirfenidone in these patients.
Yes, so pirfenidone, there's no proof, there's no evidence to prove, there's no evidence to prove that pirfenidone has any mortality benefit. One, I think the study that was done just showed that the FVC after a few months in the group that had pirfenidone was actually higher. So I think it's proved to prevent disease progression, however, does not have a mortality benefit. At least that's what the experts say. Now, I see, at least when I was back in Uganda, people use it a lot. I don't know whether they're trying to treat like post-infectious pneumonia, where someone has some form of organizing pneumonia, like what I would ideally call like some form of cryptogenic organizing pneumonia. I see people prescribing it, I think even in the COVID era, but it's not been proven to have any evidence. I wouldn't use it, yet it has the side effects. Again, you can take everything I say with a grain of salt, because it's just expertise, but it's expert opinion, but at least there's no evidence, and I rarely see it being used here. I see most most of the time people using steroids for what I guess the respirologists term as a cryptogenic organizing pneumonia. Someone may have COVID and then that sort of translates into, it gets to a fibrosing stage where the infection or there's no more viral replication. And so the issue now is just, the patient is still on the vent and taking so long to move from the vent because of some sort of fibroblastic process.
I see you just came to kill our hope this evening. So we thank you so much. And it's been an excellent session. Thanks for your ideas. May the conversation continue. Some of us know Joyce's contact, so we can always chat with her further on any other questions we have. So Doctor, kindly retire your slides. I would like now to introduce the final speaker of the day. Perfect. All right, so our evening is about to reach conclusion. So permit me for a few minutes to have Dr. Preach give us his closing and take-home comments for the day. Dr. Preach is an internist and intensivist working in Cambridge at the moment. He's one of us and is quite passionate about medical education and definitely making a difference here. He mentored the team that has presented today and has given us quite a lot of discussion points. Dr. Preach, over to you, sir.
Thank you very much. I would like to thank all the presenters for the very wonderful presentations you've made. Thank you very much for bearing with the multiple discussions and iterations of your presentations that we had to go through. To the audience, thank you very much for staying till this late on a Friday evening. We really appreciate your attendance. I think the take-home message is that restrictive lung diseases can be either intrinsic or extrinsic. The intrinsic one, by the time they have an acute exacerbation, they are unfortunately heading towards the end of their lives. And it is important to have reasonable goals of care and you alert them early on. It's normally a difficult conversation, but patients will actually thank you for being honest with them, even in difficult situations. For the extrinsic lung causes, especially mechanical problems that can be easily reversed, like abdominal compartment syndrome, it's good to just go ahead, crack on, and get it sorted. The earlier, the better. However, it's difficult. It's a difficult disease process, the restrictive lung diseases. So your approach should be in such a way that you are willing to learn even from the way your patient responds. Unfortunately, the patient who was in our presentation, from the look of things, he honestly didn't have very long to survive. The team did a fantastic job in bringing him that far, but then his outlook, honestly, it's poor. So take-home message for the restrictive lung diseases, the intrinsic ones are very difficult to manage. And please be honest with the patient early on. They will thank you for telling them the truth, of course, in a gentle, guided manner. Otherwise, thank you all for participating in this presentation. Thank you.
Lovely, lovely, lovely. And thank you very, very much to all the presenters of the day, right from Dr. Daphne, who gave us the case, Dr. Jonathan Mukenyi, who took us through the twists and turns around pathophysiology. Then we had such a lovely talk on pathophysiological basis of therapeutics from Dr. Owori, and finally, Dr. Joyce for her lovely talk. So as usual, I get my final seconds to just share a bit of what I've picked up for the day, and hopefully that you'll also take home. In this particular case, I've learned that this is an annoying disease where the lung is not able to take in air, but it wants to exhale. So in other words, the capacity is limited, the lung recoil is quite excessive. And unfortunately, predominantly caused by progressive disease with a poor prognosis, and therefore this limited outlook of conventional therapies. And you really want to get this guy and hope and pray that you have a reversible cause versus an acute exacerbation of the underlying progressive disease. Because, I mean, the patient is screwed if they are having a progressive disease and really might not start end of life discussions. And definitely your management also has to consider the fact that these patients will die, sometimes in spite of your best approaches to care. And so less is more. Early involvement of palliative care is key. And trying to notch a diagnosis early enough might help to give direction to care and save cost, avoid the false hope of putting a patient in therapy that might not help them. For example, now we have high flow oxygen, which in some affluent families can even be set up in their homes. But the question is, will they benefit from it in the long run? For sure, some people might have their clear goals of care. They probably want to spend some more time with their loved ones, and maybe this oxygen therapy might be helpful. But it looks like without a transplant, these guys are gone, and yet the criteria for transplant are extremely to agree on what is possible and the journey ahead, and the reality that a patient could die with or without transplant medicine. So yes, so basically that brings us to the conclusion of our conversation on restrictive lung disease. So over to next week, Friday, we shall be having a new episode that will be tackling pleural spaces in the critical care setting. So go and read, involve a lot of thoughts, a lot of questions, so we have a productive conversation, and tell a colleague to tell a colleague to tell a colleague. So I thank you so much for attending. Thank you for being part of this, and I wish you a great weekend. Thank you. Bye-bye.